The AACN Academy combines education and experiential learning to enable nurses to design, implement, and measure outcomes of a change project that improves patient care or positively impacts their unit and/or their hospital. To date, we've completed the program in 6 regional cohorts and currently have 2 other active cohorts. Our speakers today were part of our North Carolina cohort located in the Raleigh-Durham area. And now I'll turn things back over to the moderator.
Thank you, Marion. This webcast will include approximately 40 minutes of content, and due to the short nature of this educational activity, there will be no CE or CME offered. You are invited to ask questions of our presenters throughout the webcast. You may do so by typing your question into the question box in your GoToWebinar panel. Questions will be addressed after the presentation. You will also have the opportunity to participate in several interactive polls. When you see a poll, simply click the bubble next to your choice. This webcast will be available at www.ICULiberation.org or on SCCM's YouTube channel the next business day. We invite you to share this and the many other ICU Liberation webcasts and patient stories with your colleagues widely. You may post on Facebook if you like this webcast, or if you want to tweet, hashtag ICULib during this webcast to spread the word. In addition, this presentation will also be posted on the Project Dispatch website at www.sccm.org/projectdispatch. It is my pleasure to introduce our presenters for today. Our first distinguished presenter is Kristin Geyer. Ms. Geyer is a clinical lead to the EPM project at Duke Raleigh Hospital. Our second presenter for the day is Kristin Merritt, Nurse Manager of Operations in the Intensive Care Unit and Neuroscience Unit in the same institution. They have no relevant disclosures. Now I will turn the program over to Kristin Merritt.
Hi, good afternoon. This is actually Katherine. I'm going to start off for today. And Kristin and I are very happy to be presenting our work to you today. We've worked very hard over the past 3 years to bring early progressive mobility to Duke Raleigh's ICU, and we hope our passion for our patients and for the project will really shine through. Before we jump in, we just want to say a couple of things. The evidence behind early mobility in the ICU really is a well-established concept, yet when we started our time at Duke Raleigh, we found that bed rest was still the golden rule for our critically ill patients, and over the last couple of years, we've really heard the same from many of you. So what we observed was that even our non-ventilated post-surgical patients who were being mobilized weren't being ambulated consistently or the same way, meaning that there was this big gap in how we assessed, screened, and progressed, collaborated, and even evaluated the mobility goals for all of our patients. So that practice gap really continues to exist between the well-established evidence and the successful implementation of an early mobility program. So the critically ill patient population has that gap still. So through the webcast, what we hope to help identify are methods of implementation in interprofessional practice, application that will aid in your success with mobilizing your ICU patients. So that leads us to say that the success of a project of this scope is really all about that base. So that's what the reference of our title of our project is. It's all about that base, and maybe that's not what Megan Trainor may have been referring to. That was a totally different kind of base, but you'll get the pop culture reference soon enough. We were asked to talk to you about early mobility in the ICU because we've had great success with our project and with our involvement in the CSI Academy. As clinicians, we came in knowing the importance of early mobility in the spectrum of ICU care and in the quality of life for our patients after they leave the ICU. So we're not going to give you any groundbreaking information on how to build a protocol today because, like we said, all that stuff is well established. What we want to focus on today is how to lay the groundwork, or how to talk about that base for your project that will lay a foundation of success, because that's what we've heard from about your struggles over the last couple of years from so many of you. Your interprofessional barriers, how to maintain enthusiasm, how to create that staff buy-in, things that we've done really well with in the Duke Raleigh ICU, but things that have disabled some projects that we have been involved with or people we've given advice to over the last couple of years. It's not that we didn't have the same problems. Of course we did. It's just that we recognized and validated them. We knew that they could exist. No one was surprised when they did happen, or they were pleasantly surprised when they didn't happen at all. So by sharing those things, we're hoping to set you guys up for success over the years in changing your mobility practice and in strengthening your collaborative team. So you'll hear our theme music in the background. One of the fun things we did with the CSI Academy is that we branded our project and we all had a team name, and we were Team Walk This Way. So hopefully that won't be stuck in your head the rest of the day, that song. But we do usually travel with our theme music. And this is the original CSI team. Like Marion said, it's 4 bedside nurses that were chosen, and this is us at several educational events. So I always want to pull in, that's what we call kind of the core 4 nurses that were involved.
Hi, I'm Kristin Merritt. I just want to go over a little bit about our objectives today. We're going to talk to you a little bit about identifying the different goals and approaches for successful implementation for early mobility, and then discuss the outcomes. Some of the things that we'll discuss are how to the initial and how to sustain your project, and then also describe how the meaningful recognition and nurse leadership impacts the success or failure of the project of this scale, because it is a large project. We're going to go ahead and start, but before we dive into our presentation, we'd like to hear from you. We have 2 polling questions that we would like to have you respond to, so please take a few minutes to go ahead and respond. But the first question is, have you or your unit hospital implemented an early mobility initiative? Excellent. So 68% are saying yes, and then 32% are saying no. And our next question is, what are the biggest barriers, real or perceived, to implementation? Okay. So time and workload and staff buy-in actually were challenges of ours as well. Competing initiatives looks like it's falling closely behind to interprofessional collaboration. Again, challenges that we face. So Katherine and I hope to cover those during our presentation. And if we don't answer exactly what you are looking for, then please don't hesitate to ask the question at the end. But before we get started, I wanted to talk to you a little bit about our environment, because so a little overview of our hospital. We're a 186-bed community hospital within the Duke University Health System. Our ICU is a 15-bed medical, surgical, intensive care unit. And as from the slide, you can see we have a very mixed patient population. One of the other important points to note during our presentation is that we do not have designated physical therapists, speech therapy, or respiratory therapy for our ICU. These individuals actually cover many other units in our hospital.
So that's really important to think about when we were addressing what our initial topic would be. So at the beginning of CSI Academy, the charge from our faculty was to find an area of care that we felt was important, that needed improvement. So we met with our cohort and we kind of got that challenge, and we went back and we had a couple of months to talk to our team. So we consulted our interprofessional team from day one, and we got a lot of feedback surrounding mobility. It was seen as a vital area for improvement from a lot of our physicians, our nurses, our rehab staff. Patients were often not meeting their goals with standard written orders, such as out of bed to chair, ambulate, TID, our absolute favorite, which is activity as tolerates, to which we often joke, as who tolerates, me or my patients? But in all seriousness, those standard orders alone, they're not really appropriate for the critically ill population. They aren't directive. They aren't safe. Yes, they display a goal of maybe 3 times a day or twice a day, but what about how to get to this goal, and what about a patient-centered goal? Ambulation of the critically ill patient is more involved. There needs to be a guide for our team. I usually, when I present this in person, ask people to raise their hand if they learned how to ambulate a vented patient while they were in school, and I don't often see that anybody can say that they did. So we identified our topic, and we went to the literature, and we asked, why is this important? What is the existing data out there? We really kind of investigated. And overall, what we had discovered was that immobility can be so detrimental systemically to our patients and affects so many outcomes, and that early and progressive mobility is so beneficial and can positively affect those same outcomes. So the initial question for our team really shifted from, how can we do this? I mean, this is a hard project that has a large scope, to how can we not do this for our patients? Next slide. So I'm not going to read these to you because we all know that early is key. Deconditioning happens very fast. So if bed rest has all the negative implications systemically that you see above, you have to think about how you can positively impact all those same things, those hospital-acquired infections, the rehab time, quality of life for your patients, and a faster return to a patient's baseline functioning. This was another light bulb moment for our core team as we were kind of psyching ourselves up to take on this challenge. This was exciting for us. We have the potential to really make a difference. When I heard Dr. Wesley Eli speak at a nursing conference this year about the ABCDEF bundle, he said something that really resonated with me, and I guess I'd had it in my mind and my heart since the beginning of this project. But with all the advances in medicine, we can do a lot to save somebody's life. But we also have to do everything in our capability to preserve their lives after they leave us and to give them the best chance possible at returning to a life that they recognize and a life that they want to live. If we don't do this, what are we really saving? If you're not mobilizing your patients early and appropriately, you really aren't doing everything in your capability to do that for them, and that is a huge personal motivator for me, and maybe that will reach you or your staff. But it's something that's really always stuck with me. We set out our purpose and goals at the beginning of the project, and overall our simple goal was to increase mobility in our ICU population. We did pick a target population to focus on our data collection efforts, which was mechanically vented patients and our surgical or post-op patients. But I just want to point out that our nurse-driven protocol really was utilized across our whole medical surgical ICU since the Go Lab date. We had a lack of experience with data collection, so we wanted to pick out two populations to really measure our outcomes. So for our target population, we wanted to increase mobility in our vented and surgical patients, to decrease our length of stay, to decrease their vent days by at least 10%, to increase positive patient outcomes by decreasing their hospital-acquired infections and complications, and to decrease the total cost of an ICU stay. And then we had goals for our team. We just wanted to change and advance our unit practice to align with the best evidence-based research. And we wanted to educate at least 50% of our interprofessional team before we went live. So this is one of my favorite slides because, like I said, we branded our project, and this was really, really fun. Creating our brand, you'll see from the T-shirt that at the corner of the screen, the Walk This Way Mobility Team, that was on our sleeve, and then we kind of had our project name, Early Progressive Mobility, on the front. And while Walk This Way is a really fun and catchy tune for our kickoff events and presenting, our name was actually very intentional. By creating an early progressive mobility movement in our ICU, we were actually reframing the way our team thinks about mobility in a standardized approach. We're saying, hey, we want you guys to walk this way using step 1, 2, 3, and 4, and then we're going to be here to walk this way with you. We're going to lead and guide you. We're going to give you a framework to do so. We're going to get our patients moving after a safety screen from bed to an upright and out of bed position, following a series of defined exercises and positions with our ultimate goal to ambulating or return to what their baseline mobility status was when they came to us. The title, Early Progressive Mobility, was also very intentional. At the time when we did our literature review, we often saw that early and progressive were separated out. We heard early mobility or progressive mobility, but we found the two aspects to have equal importance to mobility, so we kind of combined them. What you'll see on the screen now, that's the back of our T-shirt. It kind of gives you that really visual representation of what that progression of the mobility will look like in the ICU. And when multiple staff members per shift can wear these T-shirts, it really creates accountability each day to educate and answer questions about the protocol on our unit, especially, this logo in particular. So if you can afford a T-shirt in your budget, I'll just tell you that people will come out of the woodwork for a free T-shirt, and it's a very powerful word-of-mouth tool. So this is the next couple slides are our action plan. This is really when we say it's all about the base or laying that foundation. This is really kind of step by step what that base looked like. First, like I said, we identified our topic, we did the literature review, we defined what early progressive mobility was going to mean for our ICU, and then we took our ideas to our key players, to our interprofessional players, and we discussed kind of the sacred cows. And that's one of the most important things we did, and a large part of our success is we started by coming up with all the reasons why, this wouldn't work for us, which is why we asked you guys that polling question. What are the struggles you've had, or what are the ones you're fearful of having? So we found out what our team thought about that, and then we addressed each fear kind of person by person, systematically before we ever conducted our first test of change on the unit. And this was a process of continued nurturing, ongoing education and communication, and this will differ from unit to unit. So the third thing we did was we developed a protocol and patient and family education, brochure, electronic medical record documentation for tracking the mobility of our patients. And then we started the test of change. So notice we haven't went live with any education or the protocol yet. First, we went to the unit to do a test of change, ambulate our first vented patient, get him walking in the hallway if that was possible, and show our team, this is relevant to us, this can work, we can do this. And so it's really showing ourselves and our peers that will help lead the way, and it created a shared experience for us. So, you don't want to go live with all this stuff and then come to find out the protocol you developed doesn't really fit well for you all. So it also addressed safety concerns, getting an alert patient walking 3 laps around on our ventilator. It showed a positive qualitative outcome. We'll talk more about that later towards the end of the presentation. There was a positive response from our team, especially even naysayers before. People were actually really shocked at the effect that this had for this patient. And we had support from the patient and the family. I'll say that timing and preparation in this were really key. Like I said, we collaborated early, and we got the important validation of concerns for this kind of hot topic. Everyone felt ownership before our big go-live rollout date, and everyone was pretty well versed in how to approach the ambulation. So we really, really kind of gave meaningful recognition for that test of change and got the word out to people who maybe weren't there that shift. So everybody was talking about it. Supportive nursing management was also key, having time to really pause and meet with our team, get our elevator pitches out, plant the seed in people's mind. So I hope as we're going through this action plan, that's what I'm talking about, harping on laying that solid project foundation. You're going to hear me say the word validate probably a million times today, because it really is all about that base, laying that base down, listening, action planning, tests of change, support, meaningful recognition. And maybe I'm getting carried away with branding even our PowerPoint, but you have to have fun with it. We had a ton of fun with this project. So we sent a lot of surveys, pre-protocol, throughout the protocol, and at the end of our data collection time frame. We'll review results later on, but responses were used to validate that, again, there's that important word, and incorporate thoughts and concerns into the protocol, the education, and the safety screening. So people saw, I was fearful of that, but that's actually built into this protocol. We had a lot of fun events with our Go Live, food and games, and we created a patient and a staff reward system. I'll show you some pictures of that, but making it fun and meaningful for everybody else as well. And then our protocol went live in April of 2013, so that's important because you'll see that there's a 5 to 6 month planning period before we actually went live with the protocol. So we really, really took the time and the intentionality to build this project up. And then we did our data collection time period, so we kind of wrapped up our data for that implementation phase, a 6-month phase, in October of 2013, and then we ended by hosting a local innovation conference in February. So this is what the protocol looked like when we still had paper orders. So this was the initial protocol. Again, we used the ABCDE bundle at the time and the AACN Pearls to structure our protocol. Our CSI faculty was really great at helping us utilize the existing evidence and adjust it to fit our unit and our patients to make it work for us. I mean, that's a big piece of advice is don't reinvent the wheel. Make it work for you. We're here to share our information today because that's our hope. Components that are important of the protocol is that it's nurse-driven. It's initiated, as a team, as discussed daily in rounds, and now it's ordered up on admission. So when a patient comes to us electronically, they have a choice for bed rest and early progressive mobility, and our providers have really created the culture of everyone gets early progressive mobility, and then it's discussed first round with the team. PT and OT, bringing them on early is super important, or a nurse can initiate that, or when a patient is at level 2. Patient and family education is built in, brochures, rounds discussion, daily goals individual to the patient, Collaboration is required, so we have, the resources for who you need to call when. Safety screening, we use the MOVE acronym. It's very straightforward. Myocardial stability, oxygenation requirements, vasopressors have to be minimal. You have to be able to mentally engage. And because of our population, we did not make absolute exclusion and inclusion criteria. We really wanted to allow for physicians to be able to modify the safety screen criteria on a case-by-case basis. This has worked well for us because we're a mixed population, but you need to consider your unit. I know I recognize in like a neuro ICU, maybe a lot more criteria, but in the past, we've also heard from people that they have a hard time getting off the ground because there is so much inclusion-exclusion criteria that they can't. It's either overwhelming for their team to learn, or they can't get off. They just can't get moving with the protocol. And then this is the levels. There's nothing revolutionary about this. Like I said, we're not going to focus too much on building the protocol parts. It goes from passive range of motion and active resistance PT, chair position in bed, to sitting on the edge of bed, to an active transfer to a chair. And that's important that it's not a lift, it's an active transfer, and active mobilization in the room or in the hallway. It really, those goals really depend on your patient. You want to be very patient specific. We did have resources for our team handy during practice change timeframe. So in that 6 months, we created this badge buddy quick reference for our team because we wanted them to have constant resources on the unit. So everywhere they turn, there's either a sign to remind them, a mile marker on the wall to remind you, oh, my patient's walked 10 feet, or just always keeping it relevant in the front of people's minds. So we had these made up, not a very expensive cost. Again, they use the AACN Pearl, and staff really enjoyed having that reference right there. This is some pictures of our kickoff events and what it actually looks like to ambulate a patient on event. It really does get easier and more efficient with practice, and the number of people required changes as the patient progresses and as your experience with it progresses. So that time and workload barrier that is everyone's fear, it doesn't really exist for very long. Once you have your comfort level, you've it's a well-oiled machine. It kind of runs itself. You talk about it in rounds. You agree on time that you're going to do it. If you have a busy day, your charge nurse can come in and implement it for you. And we don't always have a free charge, so we're talking about really collaborating with our time. And then you can see some of the pictures of the rewards, that Olympic theme we had for our patients. They got gold medals when they reached a goal. They carried the torch with their walker, which they really just got a kick out of. We had, sleep masks, basketballs you could squeeze to relieve stress, back scratchers, pedometers, earplugs. So everything was really either exercise related or, stress relieving or helping you get some more sleep. So kind of keeping with our theme. And then the mountain that you see in our staff break room, that early progressive mobility reward board, that was a competition, a really fun competition we had with our staff. So, do what you can to make it fun. Project goals, I'm just going to briefly touch on these. The CSI Academy faculty also encouraged us to make these simple, short, medium, and long-term goals, to continually revisit them, maybe give them to your manager. You need to provide some accountability measurements for yourselves as a team to kind of keep you on track. We did give formal education to 58% of our RNs, 60% of our NAs, 100% of our respiratory therapists, 88% of our doctors and NPs, and 100% of our PT/OT staff, which really, I'm going to give credit again to the test of change because everyone had already seen what this meant on our unit for our patients, for the family, for the staff. So the buy-in really just kind of increased through that test of change, and the naysayers kind of dropped off after seeing that, face-to-face. So we didn't have a problem getting people to attend our educational events. Again, long-term, we just wanted to affect positive patient outcomes and mobility. And, we still continue to utilize EPM on our unit. Challenges, I will say you should welcome them, you should expect them. They make your project better because if you've identified them already, you know how to address them, or like I said, you're pleasantly surprised when you don't actually have them, or you're just expecting them so your team isn't surprised. Data collection, I already touched on this a little bit. Lack of experience and lack of baseline data really was kind of a bear for us. I would say utilize your hospital resources early. Identify the people that can help you set up audit measurements, audit structures, how to document to keep track of mobility, and that will make your data tracking time so much easy for yourself. So we did kind of leave that out of laying our foundational base, and we kind of had to struggle with that at our 6-month time frame. Originally, I thought that picking out populations would help us with outcome measurement, but in retrospect, we may have had even stronger outcomes or an easier time with data if we just pulled all of the ICU data, because we did order it on all of our patients and utilize it with all of our patients. Low census, staffing changes, momentum slows, and your population fluctuates, so keeping it relevant, again, use meaningful recognition and continued communication to kind of deal with those low census time. And this is a good challenge. Equipment, we didn't have enough big chairs because we were getting so many patients out of bed and moving that we ran out of chairs for our patients to sit in, so we did have to, Kristin had to kind of creatively work some of that into our budget. And then time and workload barriers, like I already addressed, those really weren't as bad as we thought they were going to be. Auditing, continual education, new hires, really any of these challenges, I'll say each one was addressed by re-educating our staff, consistently communicating, giving meaningful recognition for our successes, and increasing our interprofessional collaboration. Again, all of that is validation.
And as Katherine stated, collecting data was one of our obstacles that we faced. However, we were able to overcome this challenge. We did a lot of manual data abstraction as opposed to being able to generate reports. The graphs here show our outcomes for mechanically ventilated patients for a 6-month time frame, and that's what we initially did during the CSI project. The mobility is defined by the level 1, 2, 3, and 4 of the protocol that Katherine had spoke about earlier, increased from 0 to 100% in our mechanically vented patients. We started at 0 because we're not addressing mobilization or ambulation before this period. Our length of stay on the vent also decreased from 4.6 to 3.7 days, which was almost 1 full day. And then our ICU length of stay for vented patients decreased from 7.1 to 6.1 days, which was, again, was another day. Our vent days compared to the 6-month time frame in a previous year decreased from 81 to 67 days overall. Our ICU length of stay for surgical post-op patients decreased from 7.6 to 6.9 overall. And then we also looked at our hospital-acquired infections and complication reductions. During the early progressive mobility protocol implementation and while we were sustaining it, we did see 0 pressure ulcers, 0 falls, and 0 VAPs during our time. Now, we can't say early mobility was the sole credit to why we had 0 pressure ulcers, falls, and VAPs, but because there were other initiatives in place to address these. However, early progressive mobility was a large contributing factor to these numbers and our overall standard of care in the ICU. So our initial fiscal impact of our early mobility protocol numbers are here. You can see that we decreased our vent days by 14. We decreased our ICU length of stay by 1. One vented for our vented patients. We decreased ICU length of stay by 0.7 days for our surgical patients because, like Katherine had said, we were looking at just our ICU surgical and vented population at this time. And then we also decreased our VAPs to 0, pressure ulcers and falls down to 0 as well. Overall, our initial impact, overall cost savings was $620,000. The projected fiscal impact and cost savings for a year of the intervention totaled to $1.2 million. We sustained our sustained fiscal impact of early mobility protocol. As you can see, we decreased our vent days by 20, decreased overall ICU length of stay for our vented and non-vented patients by 0.3 days, and decreased our VAE VAPs, pressure ulcers, and falls to 0 as well. As we started moving after the 6-month period, we started collecting data on all our patients as opposed to just our vented and surgical ICU patients. We started looking at all our ICU patients at this point. And again, as Katherine stated, our recommendation for the departments that have not initiated early mobility would be to collect data on all your ICU vented and non-vented patients. So overall, our sustained fiscal impact has been $846,000 from the cost savings of our 6-month to the 2014, but overall in our 2-year process was a $1.6 million in savings. And as you can see, since the program was initiated, we've had an overall $2.9 million in sustained savings for our project. So we did have some unexpected qualitative outcomes that we, for example, patients and families were so excited about our new initiative. We had one patient that was telling it all to his family about our new initiative and explaining. He was actually educating his family, so it was really interesting and a lot of fun to see him interacting. We saw an increase in our HCAP scores at 3 months and 6 months post-implementation. Our staff were recognized by our health system in a variety of forums. We have collaborated at many levels, locally, regionally, and nationally. Our team also presented on this topic at NTI in Denver and San Diego. And as the manager, I can say the best unexpected outcome has been that it has strengthened our overall interprofessional team. So everyone on our team has, it's been very exciting initiative. The other unexpected qualitative outcomes, as you can see here, these are our HCAP scores from baseline to 3 months post-protocol implementation. And then we also have a 6-month post-protocol implementation. And one of the questions that we receive frequently is, an initiative like this is causing the nurse to be at the bedside, spending a lot more time, or nurses, several nurses. However, we've actually seen that was not the case. The staff did not necessarily spend more time with the patient and family, but the time that they spent with them was educational, and it actually included the patient and family. And as a result, it reflected on our HCAP scores about the information given to the family while in the ICU. We also, as Katherine mentioned, we did conduct ongoing interprofessional team surveys before implementing the Early Progressive Mobility Initiative. The take-home was continual validation of their concerns. We used this feedback to tailor and guide our efforts for the project. And as a result, they felt heard, and they also felt ownership in the project. We recognized and validated that these factors could exist so that no one was surprised when they did happen, or pleasantly surprised when they didn't happen, actually. And as you can see, this is the pre-protocol survey results, and it assisted us in helping build the protocol, validate their fears and concerns so we could focus on the education and the other elements of our protocol. These are post-protocol implementation survey results. This is from our midway through our project, we did a mid-survey and a post-protocol survey. And as you can see, responses remained positive. The staff felt the early progressive mobility was important. They reported they felt comfortable in ambulating our patients, and they felt that early progressive mobility was a standard of care in the ICU. So some other obstacles that we faced, we continue to use these responses to look forward to our next project, Sustaining Move. We also collected a few provider testimonials. One of our nurse practitioners stated that EPM protocol has put mobility in the forefront from the VAT prevention, and nurses are more empowered to begin mobilizing their patients. We also had a respiratory therapist say the improvement in oxygenation, lung expansion, decrease in vent settings due to the increased respiratory muscle building. Also the best outcome in the increase in patient confidence and improved quality of life. EPN has raised the bar in the ICU. One of our acute rehab team leaders, she probably had the most compelling statement that we felt. She said, "I believe patients are getting mobilized sooner overall in their stay, as well as more appropriately. The coordination between nursing, respiratory, and rehab services has been much improved, with greater expectations for all disciplines and the patient's benefit. And there's more excited anticipation versus dread of mobilizing patients, which promotes staff retention. It seems there is less ICU psychosis in longer-term patients as well." And that was a profound statement from her about the less ICU psychosis, because we also noticed that we were not dealing with the delirium and the psychosis that we would normally see in our ICU patients by just getting them off their sedation faster and ambulating them sooner. Lastly, one of our managers from Acute Rehab, she said it sets the standard of patient care and serves as a guideline for everyone to follow, ensuring that mobility is achieved appropriately and timely to increase patient safety and improved outcomes. So overall, we had very positive response from, people who were part of our interprofessional team within our project.
And I'll say additionally that that quote from the rehab team leader about promoting staff retention. When I got that testimonial from her, one of the things she had said is, we maybe as a department weren't as comfortable working with ICU patients because they're not dedicated to ICU services. They split their time with all the departments. And to hear that it promoted staff retention, I mean, we were so happy to hear that from her. So very thankful for those testimonials from our team. So some additional qualitative outcomes we've had. We have had this overwhelmingly positive experience providing guidance to other teams who want some help when they're embarking on their mobility journey. And that opportunity was made available to us through the AACN Innovation Database, which really has disseminated our project in this tremendous way. So, we've helped people with protocol guidance, either simplifying their protocol or helping them with test of change patients. I would say it's a big deal to do the test of change, and you also need to really pick the appropriate patient for that test of change. You don't want to ambulate your sickest, less straightforward patient the first time you go live with it, which I've actually heard people have done, and it's really kind of disabled them. Documentation for accountability, helping people do that, or giving them examples of our documentation screens, branding to make it relevant for their staff. We've shared our logos and, anything that will work for your unit, we're happy to share that stuff. Incentives, it's not a necessary puzzle piece as opposed to the meaningful recognition, but, some of our competitions between our staff were really unique and fun. So it just, if it's something that you think will really stick with your team, I would say do it. And then the most common thing we hear about and we heard about from you all is creating, that staff buy-in. So how to lay the solid foundation prior to going live through all of that, the test of change, the interprofessional meetings, validating fears and perceptions with, building your protocol and ongoing communication and then meaningful recognition. I will say one thing that Duke Raleigh ICU has done an amazing job with from the beginning is always giving meaningful recognition to team successes versus individuals regarding early progressive mobility, and that's really promoted a sense of pride in our work and solidified our practice change.
And just a little bit more about the mobility program, meaningful recognition. We've had some more unexpected qualitative outcomes as time has gone on with our project. We have recent articles and accolades and other program recognition that has spotlighted our Duke Raleigh ICU and in our health system. And just another, we were featured on the news. We've also been featured in Forbes online, and actually a blog written here by our CEO about our patients walking out on us, but we couldn't be happier.
So we're thrilled that our team feels that way about early progressive mobility, but nothing has really impacted us quite like our experiences with our patients. And these experiences and those patient stories, they're really the things, we can't measure them by a number. It's what creates our continued investment. It's the most important reason that we would do this all over again. So when we set out, we knew we'd have an impact on quality of life. I don't think we really grasped how much of an impact we'd have on that, and especially at the end of someone's life. And so this first patient story is about the gentleman you see sitting in the chair smiling around his ET tube, and he was our gold medal patient, and this is kind of a story about quality of life at the end of his life. So he was what we called our gold medal patient. He was our test of change patient. When we approached him to ask if he wanted to be a part of early progressive mobility, our test of change and what a test of change really was, we gave him the education, the brochure. He was so excited to participate in our project. He often wrote comments. I think you heard Kristin say this earlier. He wrote comments bragging to his visitors that he was helping change lives by being the first person who does this. And, he really did. You saw the outcomes. He changed other people's lives by being this test of change patient, and he certainly changed ours. His family later noted that we gave him purpose during this difficult time. He ended up progressing to walking 3 laps with no physical assistance other than a rolling walker. I mean, doctors who had been in our institution for years were seen following him with kind of their jaws dropped, not really sure what they were watching. He had his Olympic torch flying, and his gold medal was shining, and he kept a record. He called it his world record of his achievements on the whiteboard in his room and kind of bragged about that. He had a poor diagnosis. He had advanced pulmonary disease, but with the increased respiratory muscle building and pulmonary toileting, he was actually able to extubate. And as a team, we knew that that probably wouldn't have happened without early progressive mobility. When he was extubated, his strength was intact, which gave him back some of his dignity. He was able to transfer out of our ICU to a step-down unit, spend some private time in the private room with his loved ones for a while, and he ended up coming back to us for end-of-life care. His family was thankful. We heard him say, some of them come back and say to us later that, I was able to hear my dad's voice again, and, I'll never be able to thank you enough for that. And he was given the opportunity to discuss his wants for his end-of-life care, which is just, amazing. So this is what we hope for you. Of course, we want to see those fiscal numbers for your hospital, but this is what matters. This is what we devote our lives to. So this is our hope for you and your patients. And then we have a video of a patient who actually wanted to return and film a testimonial about how early progressive mobility affected his hospital stay with us. So we're going to play that now.
I was watching the Super Bowl Sunday. I leaned back in the recliner, and I could only move my neck.
And he said, you need to take me to the hospital. I can't move.
I was diagnosed with MS a year and a half ago. Because of my MS, I have flares every once in a while.
We went to the emergency room thinking he was having an MS episode. And it wasn't long after we were there that they mentioned pneumonia. They hospitalized him. The staff never agreed on a course of action, and I was watching my son die.
I came to Duke Raleigh because they're really trusted by my family. I remember getting into the ambulance, getting here to see my dad, and then after that, it's pretty much a blur.
Calvin was intubated for 14 days prior to his arrival to our ICU, and he was very sick when he arrived to us. His vent settings were very high.
His admitting nurse asked him what his goals were, what he wanted to achieve, and his first statement was, I want to be able to rely on myself again. And she wrote it on the board so he could look at it every day. They knew what his goals were, he knew what his goals were, and they all worked to achieve those goals. From the very first day, he was told, we're going to get you out of bed.
In the past, patients like Calvin would be sedated heavily just because they were intubated on a ventilator. And now Duke Raleigh Intensive Care Unit initiated an early progressive mobility program for intensive care patients to get the patient out of bed to walk. What the research has shown is that it decreases the length of stay, decreases mortality rates, decreases intubation days.
We'll count to 3, and then we'll help you to stand.
We were able to dangle him on the side of the bed. We were able to get him into the chair, ventilated, and then shortly after he was increasing building strength, we were able to walk him around the unit.
Once he was on his feet and he was moving, everyone was just going along with him. It was remarkable to watch. It was teamwork.
It was pretty awesome to be part of a group that was thinking out of the box, let's do this. That was awesome. If I walked the whole lap or if I walked just a little bit, their game plan for that day was to simply walk.
We usually have respiratory therapy involved, a nurse and a physical therapist. It's very exciting. It's like the whole team is just standing there cheering this patient on to, keep going, because we know it's so beneficial. We know, probably the next day we're going to be able to get them extubated because we're just making their lungs stronger.
This is a dedicated staff, and they work extremely well together. So that's just amazing.
There are people who you pass and you meet that you know that you can just put your trust in, and I could trust his care. I am a strong believer in faith. Faith put us here, and I have faith in the services that Duke Raleigh provides.
So there are a few lessons learned when we implemented our project. Our bedside can affect change on a large scale. So we also had a lot of support from our ICU team, and our team met practice change with excitement. We've also seen many doctors wowed since we've been walking our patients, our ventilated patients, and just patients in general. They're getting up more, whether they're intubated or not. And then we've had tremendous support from all the way from our nursing assistants to our executive team. We've also noticed a difference among our interprofessional team. Our RNs are more involved in different aspects of the patient's care. We've also had a tremendous support from our intensivists, our APPs, and as well as our respiratory therapists and physical therapy. But most importantly, really our nursing staff has, really pulled together, because sometimes we don't always have physical therapy or speech or OT or anybody that can come and assist the patient and at the times that we want to get the patients out of bed. So our nursing team has really pulled together to assist that. We've also raised the bar on the standard of care that we provide our patients and their loved ones. Finally, as a nurse manager, one of the lessons learned that I did provide the staff with some indirect time, which is non-productive time to some other organizations. And it wasn't as much time, probably about 20 hours, maybe 30 hours. And because of that, the payback has been it's been in dividends, because we were able, even though I gave them this time, this paid time to go and work on this project, we've actually had, $2.9 million in savings, or $2.1 million in savings. So I think being able to pull them out has been a lesson learned for me and for my executive team as well, that it really does pay off in the end. And now we're going to go ahead and turn it over to the moderator for questions.
Thank you so much, Kristin and Katherine. We really appreciated this presentation and all the information that you shared. We do have some questions from the audience. The first question asks, ARDS patients are often on low tidal volume, and that can be uncomfortable. So was it better to do low tidal volume and no mobility, or more comfortable vent settings and ambulate them? And did you all have situations like that you dealt with?
Chris, I'm going to let you take this one. I would say that for each patient, it's totally different how we addressed it. It really depended on the individual patient.
Okay.
We did use our safety screen too, and our criteria. So depending on what the criteria was on our protocol and whether that patient met the criteria would depend on what level they were and whether we would actually even consider dangling them versus standing versus ambulating around on a vent. So it just really goes back to that protocol, which we can post and send to people, and it's also on the AACN website.
Okay. Thank you. So we have someone who says, congratulations for your presentation and the implementation of this wonderful program. I wonder how awake and mobilized patients deal with their artificial airway. Do they gag on the tube?
Surprisingly, no. One of the things that we have gone to almost minimal restraints here in our ICU as well. And surprisingly, we do not have a lot of self-extubations, a lot of restraint usage, and we don't see, when patients are getting up, mobilizing, we don't see them gagging either.
Yeah, I would say no for sure. And I mean, being a bedside nurse in our ICU, there was a huge fear of self-extubation as well, with the restraints being off. And honestly, with the decrease in delirium, I mean, we have people who are doing their own oral care on the vent because these people are awake and alert and communicating with us better, telling us their needs. So, I mean, the care that they're getting has exponentially just in all aspects it's really just enhanced all of that care. And awake patients doesn't mean that they don't have pain management, that they don't have any like low rate of pain management going. So yes, they are awake and alert, but we're still addressing those things for comfort as well.
Okay, thank you. We have a question that asks, have you ever walked patients on CRRT?
Kristin, I've been out on maternity leave, so and I know in my experience we have not walked a patient on CRRT due usually to line placement.
Right. It's because usually of line placement. But I do know in our organization we have walked patients on ECMO, but not here at our.
And then the next question is, do you have any anesthesia and sedation order set to support this, and what was pharmacy's involvement in creating those?
We do have a sedation agitation protocol, and pharmacy has been very involved with our intensivists in doing our sedation, spontaneous awakening, and spontaneous breathing trials each day. But it's again an interprofessional collaboration of all the team members that are discussing that, and it's being evaluated every day. We have certain criteria in place where we would wean our patients off their sedation and do spontaneous breathing trials, and then we would, score them as far as, safety screen and what level they're at, and then depending on, we would, start the mobility, like dangling on the side of the bed to a chair to possible ambulation.
Okay, thank you. We have a question about, did you have portable ventilators, or did you walk them with the ventilator they were connected to?
Our ventilators are actually portable. They're not, small like you might think of a portable ventilator, but ours go with us everywhere, so we're never breaking that circuit.
Okay. Next question is, do you have EPM data on trauma patients? Did you have trauma patients in your ICU also?
No, we do not have trauma patients.
Okay. Do you have data correlating your delirium rates and early mobility? I know you spoke of that was an unintended consequence, but did you measure that?
We did not measure that because at the time of go live we didn't have a PAD protocol that had went live. It was in the works, and it is now live. So as we move forward with our data collection, that should be something you all should look for us to report, because hopefully our outcomes will positively support the bedside experience that we've had.
Okay. Did you at any point measure muscle strength to monitor their progress?
We did not specifically measure muscle strength.
No. And then there is a question, there's a lot of people and things involved in ambulating a vent patient. Is there a minimal level of activity for getting the patient up and moving? And the example is, if they can only walk 10 feet for 30 seconds, is that deemed a success for everyone involved?
Absolutely, because that, 10 feet turns into 20 the next day. Like I said, everybody's goal, level 4, ambulating in the room, marching in place, ambulating in the hallway, it's going to be different for everybody depending on, their reasons for admission, their diagnosis, their age, any of their demographics, really. So, yes, anything that's a goal reaching, that's definitely considered a success. We celebrate all of it.
Okay, thank you. As a result of this project, do you now have more dedicated rehabilitation staff?
No, we do not. We do not. It's something that my ICU medical director has requested, that we would possibly have a dedicated physical therapist for our unit, but it's not something that has come to fruition.
We certainly have a case for it. Yeah.
Okay, thank you. So a question about how do you sustain your gains in terms of when you get new staff, whether it be nursing, physicians, respiratory therapists, pharmacists, physical therapist, how do you sustain your gains? What kind of orientation things do you have built into your orientation?
Well, from the nursing side of, our preceptors are well vetted in the early mobility process. So they're training the new hire to learn about the mobility program and our protocol and what the screening tool is. During interdisciplinary rounds in the mornings, there's a lot of education that goes on as well, because it's a discussion that happens every day on every patient that we have critical care following. So as far as PT, and I'm not sure, and respiratory, I know they are part of our team, but as far as PT, I'm not sure what their orientation process is.
It's the same as nursing, really. I'll say that I've seen them, because they have a preceptor in the same style that we do, and I've seen them at the bedside orienting them to the different levels and to the different types of collaboration that goes with it, and discussing it at rounds, and really letting the new hires be a part of that. And then I will say the health system is going live with some mobility efforts across all the ICUs, so there will be a more formal education piece to come out with that as well.
Okay, thank you. And so a question about, did you involve your families in helping to assist to ambulate, and how did you do that?
Well, if possible, absolutely. Like I said, you'd be surprised at people's strength after a couple of days of ambulating, even on the vent, or we've always incorporated in our non-vented patients, whether it's being a cheerleader, holding the monitor, just anything that they can walk right alongside of us, ticking down the feet, because we do have mile markers around our unit for encouragement to let the patient know, okay, now you're at 20 feet, now you're at 40, and kind of adding up how much they've ambulated. It makes a big difference. But once everybody's kind of trained in it or well versed in it and they have a comfort level with it, the family is absolutely welcome to participate. But there is an understanding with our vented patients that they don't ambulate, or any of our patients, really, depending on their status, without the help of nursing and our interprofessional team.
Okay. Thank you. I want to thank both of you today, Katherine and Kristin, for this great presentation. And I want to remind everyone on the phone that this webcast will be available at www.iculiberation.org or on SCCM's YouTube next business day. We invite you to share and continue this conversation on hashtag ICU Liberation, or to post on Facebook. And we want to thank everyone for joining us today. Thank you.